So this is a double contrast study. Excuse me. As far as the patient prep we've talked about before, light evening meal is probably not a valid statement. These patients are typically 2 days without much substance as far as food goes. They're allowed clear broth. They are allowed Jello, Gatorade, things like that, but nothing with real substance. They are on all kinds of bowel cleansing cathartics or laxatives. No gum chewing, no cigarette smoking, and they typically have to do a Fleet's enema. Remember, they also have to do typically either mag citrate, the castor oil, something along those lines to help clean out the intestine. Like we said, the cathartics, there are irritant cathartics, which are your castor oil, and then the saline, which are your mag citrate, mag sulfate, things like that, the bisacodyl or Ducalox. And then any contraindications to the cathartics would be some kind of gross bleeding, severe diarrhea, possible obstruction, or any kind of inflammatory lesion. The contrast media we talked about it's typically single use closed system kit. Now this is actually a picture of a single contrast enema bag, but the double contrast enema bag is what we would actually use. We talked about the fact that we want to use room temperature water. It is a colloidal suspension, so we have to make sure it's mixed well before we actually use it, and that we can also use glucagon and give that to the patient intravenously if they start to experience spasm. I also mentioned before that you can add an anesthetic like lidocaine, liquid lidocaine, to the actual bag itself. So this is where I'm saying that some of these slides are repetitive, but just to kind of go through them quickly and explain what's going on. The enema tips we've talked about, but the one we're going to use with a double contrast enema is this double contrast retention tip. We said that this particular thing right here goes to the air cufflator that inflates the retention balloon right here, and this actually attaches to a bulb syringe, and that's actually how we inflate air into the colon once the radiologist instructs us to do so. The room prep is just like all the other procedures, except that the table is actually horizontal for this. The Bucky would be all the way at the end to bring out the Bucky slot shield. You would have an IV pole to hold the enema. Probably have linen on the table, extra linen like towels, extra sheets, and extra gown for the patient just in case they actually have an accident. The enema prep, as far as the preparation, remember that the bag, the double contrast enema bag will go on an IV pole no more than 24 inches above the table, and the patient ends up lying on their left side in position to actually insert the enema tip, and their right knee is flexed for that. The insertion is the same. It's going to be up and towards the umbilicus, and then once you get the enema tip in place, we are allowed to put in 1 puff of air in the retention tip. Any more than that would have to be done under fluoroscopic guidance. Typically, I tell you that you have the patient take in a breath and blow it out, and you actually insert the enema tip on exhalation. I'm quite sure you guys can hear our bird in the background. I apologize for that. The more I try and tell her to be quiet, the more she talks. So, sorry about that. Gloves, you're typically going to have 2 pair on so that once you get the tip in, you can pull off the top pair and throw those away, and then you'll have the second pair on because it's so hard to get those on once they actually, once your hands are sweaty. And we always lubricate the enema tip prior to inserting it into the patient. Like I said, the tip goes up and towards the umbilicus when we're inserting it, and you insert on exhalation. Okay. Some of the safety concerns we have, you always want to review the patient's chart. You never want to force the enema tip. If you can't get that enema tip in, what you would do is let the radiologist or the fluoroscopist know, and you would have it inserted under fluoroscopic guidance. That way there's no potential for perforating the rectum. Like we said, the enema bag should be no more than 24 inches above the table unless you're directed by the physician to do so. And you want to make sure that the temperature of the water that you mix with the barium is room temperature. I had said that you could run it on the inside of your wrist and make sure that it's not too hot, not too cold, but that it feels just right. Now, we've already talked about a single contrast enema, so today we're going to talk about a double contrast barium enema. We're going to talk about evacuative proctography or defecacography, and we're also going to talk about a colostomy enema. With the double contrast enema, we actually use barium and room air. So the barium is our positive contrast media or our radiopaque contrast media. And the room air is actually our negative contrast or our radiolucent contrast media. The barium that we use tends to be thicker because you actually want it to stick to the lining of the haustra. You can see in here it just kind of outlines the haustra. It's forced against the edges of the intestine. There's still some barium in here, but you're able to visualize inside the lumen with a double contrast enema. And that's important to look for things like polyps, because if you remember, polyps pouch inward. So you're definitely going to be able to visualize polyps much better on a double contrast BE versus a single contrast BE. And we actually do what is called a two-stage procedure. And that two-stage procedure is actually on page 506. Okay, for a double contrast enema, like I said, we use barium and room air. And we talked about with a single contrast enema, we use 2,500 cc's of contrast. With a double contrast enema, it's thicker barium, and we only use 1,500 to 2,000 cc's of thick barium. Okay, so 1,500 to 2,000 cc's. And the two-stage procedure, that is discussed on page 506, about halfway down the left-hand side of the page. And it says that one preferred method is a two-stage double contrast procedure. So what you do is the thick barium is allowed to fill the left side of the intestine up through the left splenic flexure. Now this is done under fluoro. The radiologist would direct you to turn the barium on. You would say barium on. You would follow it. The radiologist would also follow it, filling the rectum, the sigmoid, and the descending colon all the way up to the left splenic flexure. And it says that the purpose of the thick barium is to facilitate adhering to the mucosal lining. Once it goes through the left splenic flexure, you push air into the bowel. So the radiologist would tell you to pump the air with that bulb syringe, and it pushes that column of barium across the transverse colon up to the right hepatic flexure. And it says at that time the radiologist can ask that the enema bag get lowered below the table to allow excess barium to drain from the large intestine. So at that point, once it reaches the right hepatic flexure, typically the radiologist will tell you to place the bag on the floor, open the clamp, and allow the excess barium to drain. Sometimes they actually will raise the table slightly to help drain more of it. Once it drains to his satisfaction or her satisfaction, they would clamp it off, and they would tell you at that point to squeeze the bulb syringe and continually pump air into the large intestine. Now what it'll do is actually move the main bolus of barium forward, so it'll complete through the right hepatic flexure, and it would continue down the ascending colon. And it says that by doing that, it leaves behind only the barium adhering to the mucosal wall. All of this is done under fluoro because the air cannot get in front of the barium. So the radiologist has to be very mindful and watch this. If the air gets in front of the barium, and this is not in your book, then what happens is if the air gets in front, the air would end up getting into the cecum. And if the air gets in the cecum, there's no way for the barium to fill the cecum. And if the cecum is not filled with barium, then what happens is you have an incomplete study. It's called an airlock in the cecum, and you would not fill the cecum with barium. So that would be deemed incomplete, which means at that point, the patient would have to re-prep for this exam. And if that happens where the air gets in front of the barium, that is either the radiologist error or the technologist error. It is no error on the part of the patient. So imagine having to tell that patient that they've gone through all of that and then, whoops, the air got in front of the barium, so you need to re-prep and we need to do this all over again. Not a good time for the technologist to have to tell the patient that. All right. And then once you get all of that air in, at some point radiologists would tell you to stop, and no more barium would go in the patient, obviously, because the bag is on the floor. So we don't raise that up again once it's dropped to the floor. But the radiologist may tell you to keep pumping air as you take pictures. It's possible that he or she would tell you after each picture to pump 1 or 2 puffs of air. Now, why? What can happen is once the radiologist leaves the room, a lot of times the patient feels very comfortable with you, and they might actually let some of that air slip out. Yes, what you're thinking is true. It comes out in the form of the patient passing gas, and they usually feel more comfortable with you, so they allow that to happen versus in front of the radiologist. If that happens, you have to try and tell the patient they need to hold on to that air, because that's the only thing keeping this large intestine open like that and allowing that barium to stick to the wall. If they get rid of too much of this air, then what will happen is the intestine will actually collapse and you won't be able to make out the lumen of the intestine. So it is possible that they have you pump air in between each picture. Now, the routine overheads for a double contrast study are the same as they were for the single contrast, except we add 3 decubes into the routine. So with the single contrast, you know, we did a scout, which we do a scout here as well. And then after fluoro, we did the AP axial butterfly, the AP, the RPO, the LPO, the lateral rectum, and then we did the post-evac. With a double contrast, you still do the scout, and then once you're done with the fluoro, you actually do a right lateral decubitus and a left lateral decubitus. Those are your first images so that the intestine is the most full of air. After you do that, you would do your AP axial butterfly, followed by your AP, then your RPO, your LPO, your left lateral rectum, and then we do what's called a ventral decube.